Welcome to The Explainer. You know, as an endocrinologist, you're on the front lines for so many diagnoses. Today, we're diving into one that's rare, but one you're very likely to see first, Wolfram Syndrome. We're going to walk through a really practical guide to spotting it and managing it, based on what the latest clinical protocols are telling us.
All right, let's jump right in with a clinical puzzle. I bet you've been here before. You've got a pediatric patient, they're insulin dependent, but surprise, their autoantibodies are all negative. You're at a crossroads, right? So, what's on your differential diagnosis?
So when you get that exact situation, a kid who looks for all the world like they have type 1 diabetes, but without those classic autoimmune markers, that's your cue. It's a huge signal to start thinking outside the box, beyond the usual suspects. It's time to pull up that mental list of rarer genetic syndromes, where diabetes, well, that's just the tip of the iceberg.
And that dilemma we just talked about? It often points directly to one specific diagnosis, Wolfram Syndrome. You know, this is one of those conditions you absolutely have to keep on your radar. Why? Because catching it early is a total game changer for managing its progressive multi-system impact. Okay, so what is Wolfram Syndrome? At its core, it's this rare, autosomal recessive neurodegenerative disorder. And there's a super helpful acronym to remember the main features. DID mode. That's diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Now keep in mind, not every patient is going to have the whole set, but this little acronym is your key to remembering the constellation of symptoms you need to be looking for.
So, how do you actually make the call clinically? It really comes down to a specific set of criteria. You can confirm the diagnosis in two ways, either with two major criteria, and that means insulin-dependent diabetes and bilateral optic neuropathy, both starting before age 16. Or you can diagnose it with one of those major criteria plus at least two of the minor ones, and those include things like diabetes insipidus, hearing loss, or other neurological issues. All right, let's get into the part that's right in your wheelhouse, the core endocrine stuff. The endocrine system is, without a doubt, central to Wolfram syndrome, and honestly, that's why your role as an endocrinologist is just so incredibly critical, all the way from that first suspicion to the lifelong management of these patients.
First up is the diabetes mellitus, and it's a bit of a strange one. It's almost always the first sign, popping up at around age 7 on average. But here's the key. It's not autoimmune. The root cause is actually beta cell loss from endoplasmic reticulum dysfunction. What does that mean for you in the clinic? Well, these patients are insulin dependent for sure, but they often hang on to some residual insulin secretion for years. This can be a little misleading because it might make their glycemic control look deceptively easy in the early stages.
Okay. The next big endocrine red flag is central diabetes insipidus. This usually shows up later, typically in the second decade of life, for a pretty significant chunk of patients, somewhere between 40 and 75%. So here's the clinical pearl. If that young patient of yours with non-autoimmune diabetes mellitus starts developing polyuria and polydipsia years later, central DI has got to be high on your list. It's a classic sign that the syndrome is progressing.
And that brings us to another really key area for you to watch, puberty. Primary gonadal atrophy is surprisingly common. It affects about half of all adolescents with Wolfram. So what this means is you have to be super vigilant. You've got to be actively on the lookout for delayed or arrested puberty in boys and any kind of menstrual irregularities in girls.
Now here's some really exciting stuff on the therapy front. Because we know the underlying problem is this cellular stress, it opens the door for some pretty unique treatment angles. Research is pointing to therapies that could actually help with beta cell survival. Think about GLP-1 receptor agonists like exenatide or liraglutide. They might not just help with glycemic control, but they could actually help preserve those precious remaining beta cells. We're talking about potentially altering the course of the disease, which is huge.
Okay, so we've talked a lot about the endocrine side because that's usually the entry point for the diagnosis. But it's so important to remember that Wolfram is a systemic neurodegenerative disease. And as the endocrinologist, you often end up being the quarterback for the whole care team. You really need to have a handle on all the other systems that are involved so you can coordinate care effectively.
So let's break down those other systems. The O and D in our DID acronym, optic atrophy and deafness, are just the start. You'll see neurological symptoms like cerebellar ataxia and brainstem dysfunction develop over time, and you really need to pay attention to the urological system. I mean, neurogenic bladder is incredibly common. We're talking up to 90% of patients. Spotting these other features is just absolutely crucial for getting those proactive referrals in and making sure the patient gets truly comprehensive care. This timeline here gives you a really powerful snapshot of how the disease typically unfolds. You can see it starts with diabetes mellitus, usually around age 7. Then optic atrophy follows, maybe around age 10. By 15 or so, diabetes insipidus and hearing loss often kick in. And then, in the late teens and 20s, the neurological and urological problems start to appear. Having this roadmap in your head is a game changer because it lets you provide anticipatory guidance and know exactly what to screen for and when.
So, what does this all mean for you, day to day in the clinic? How do we pull all this together? Well, since you're the one managing the very first and most consistent part of the disease, the diabetes, you naturally fall into the role of the central coordinator for these patients. And it's a complex, lifelong job.
And here's a really practical, evidence-based schedule to guide that long-term follow-up. Look, this is about so much more than just checking an HbA1c every 6 months. Your job extends way beyond that. It's about making sure these other absolutely critical checkups are happening, like annual visits to a urology and neurology, and seeing ophthalmology and ENT every couple of years. You really are the hub of this whole multidisciplinary wheel. And if you want a bottom-line trigger, the official guidelines from the National Diagnostic and Care Protocol make it really simple. They say, the attending physician should discuss Wolfram syndrome in a child who develops insulin-dependent diabetes and bilateral optic neuropathy with no known cause. It really boils down to that key combination, diabetes plus vision problems.
So let's just wrap this up by saying this. Your role is absolutely pivotal. Because you are on the front lines managing pediatric diabetes day in and day out, you're in the single best position to catch this disease early. And making that early diagnosis, it can completely change the trajectory of a patient's life by getting them into proactive, multidisciplinary care from the get-go.
So I'll leave you with a final thought to take back to your practice. How can we get better at this? How can we be more systematic? Maybe it's about consciously integrating simple screening for vision and hearing issues into our routine pediatric diabetes care. Because by being just a little more vigilant for these extrapancreatic signs, we can make sure that our patients with rare syndromes like Wolfram get the full diagnosis they need, and just as importantly, get it a whole lot sooner.